Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high-quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Jessilin, what up, girl? How are you?
Hello, Jackie, and hello to all of our listeners. I have had such a fun week. I just have to talk about these, the cool thing about dry eye is that we've had all these new innovations. And I feel like the last few weeks I've done a lot more Cam 360s and I got loops in. And I'm just changing my approach to lacrophil. So I feel like it's been fun. I'm doing things that I've kind of done, but just a little bit different. And it's just, it's re-energizing.
Oh, wait. You're using loops for lacrophil as opposed to putting them in the slit lamp.
Yeah, because before I was doing the slit lamp, and then because I don't really use loops, right? Like I'm not a surgeon, so I'm not doing it. But I was like, I'm just curious if this will be easier, harder, which one. So I ordered some, and at first I was a little put off because I thought that loops would be like, I don't know, thousands of dollars. But I found some very affordable ones that are like $35 or less. And for what I'm using them for, they work great. And so it's kind of been like a fun challenge. So
Oh, look at
yeah.
this. Protocol, how you do stuff is always changing, right? That's great. Maybe I need to order some loops. You have to share with me where you got $35 loops. I'm
I'll
very
send you the
interested.
link. For sure. But in part of that, I'm just looking at the cornea a lot differently. So I'm really excited to chat with today's host, who is just like a corneal goddess.
Oh, wow. I should change my Instagram handle.
You are. I feel like, we have this. I feel like I'm here with the Boston Babes because we should. This is like kind of the guest who our guest is. But I've got two Boston gals here, and so, but we sometimes share patients, and we'll intro you, officially in a minute.
Sure.
Sometimes whenever I have weird pathology, I'm like, I just gotta send this patient to Bita, we just gotta see what she has to say about this. But Jackie, let's tell our listeners who we have here.
Okay. So people probably know just from her voice, but we're so happy to have Bita Asghari on our podcast tonight. So let me tell you a little bit about her in a more formal introduction. So Bita is equally passionate about education as she is about patient care. She enjoys working with students, lecturing, and writing for publications with her professional goal of expanding the understanding and scope of treatment for ocular surface diseases. She's literally won all these awards. I'm going to tell you some of them.
Good Lord, no.
Yeah, here they come, Bita. Okay.
It's like my mom at a PTA meeting or at a Sunday dinner.
I was like, I have done nothing compared to Bita. Okay.
Oh my God, Jackie, stop. Oh,
okay.
Goodness.
She was elected as a top doctor by the National Keratoconus Foundation in 2018 and as top young OD by Women in Optometry FAAO Awards in 2021. And she was a poster winner for her presentation at the Heart of America Eye Care Congress in 2017. She's also the recipient of the Ocular Instruments Award of Excellence. I didn't even know what this was, but that's incredible. And the VSP/AOF Practice Excellence Scholarship. And the best award yet, she's growing an actual human. Bita's pregnant.
There is a baby. Right. There is a baby in this belly.
Oh my God. Bita, thank you for coming. And you are in Boston, and I didn't even say where you work, but you work at the incredible Boston site, home of the Pros Lens. So
yes, this is true.
Incredible office. Really, I'm so happy to have you to be talking about sclerals and dry eye disease and the Pros Lens and whatever else we want to talk about tonight. And so thank you for being here, Bita.
Thank you. And if you're ever taking opportunities. If you want to be my hype girl, literally anytime, you
Just
can just
Jessilyn and
come
I will
on
do
up.
that. We will be here for you. Absolutely,
Thank you.
absolutely.
And it's so funny that Jessilin calls me a Boston girly, because I've like lived in Southern California for so long, and I've been here for so long. It's like, man, I kind of am a Boston girly now. It's crazy how things change. Maybe I'll drop a couple wickeds in there for you guys. Maybe
Oh,
that'll
yeah.
really cement it. Yeah.
For being a Boston person, we sure don't see each other ever.
No,
So,
no. Generally
my
the airport
neighbor,
or across the country.
I
Yes.
know, I know. That's it. Anyway, well, okay, we're super happy to have you here and for you to drop all of your knowledge on us on the pros lens and sclerals and help us help our dry eye patients. So, like, just let's start out with how do you tackle corneal pathology? You certainly see an insane amount of pathology in your office, and how do you tackle that and dry eye disease? What's your
Oh gosh, that's okay. Well, I'll start by saying, to me, saying like dry eye disease is saying as general as like back pain or headache. It's just such a broad term. I think traditionally maybe there's a certain naivety to the way that I'm thinking about it. But when I think of the general understanding of dry eye, people really know meibomian gland dysfunction. We've done a great job as a community, as industry, everything to push forward the understanding of meibomian gland disease, blepharitis, lid disease. And it's so tangible as optometrists, right? To see that, inspect that, treat that, and get that kind of reward feedback from patients. But dry eye, in a very specific way, yes, evaporative dry eye is one, but you have all these other conditions that tend to fall into that category. So when you're asking, how do I tackle corneal pathology? The first thing is starting with a really, really solid exam. Because I can't tell you the number of times patients will come in, and we're all referral based, but patients will come in maybe, something as nebulous as corneal neuralgia, corneal neuropathic pain. And it turns out it's not that, it's exposure. And they have incomplete blinks, or somebody who has, they're considered just to have meibomian gland dysfunction, and yet they're diabetic with bilateral neurotrophic keratopathy. And so I think when I think of just looking at the cornea, you kind of have to, or how I dissect corneal pathology, it really does come down to anatomy and a really thorough baseline exam. And I am not shy about pulling the lids up and away and everting them, throwing lissamine on there, all that jazz. So it really starts with that baseline and keeping your mind open. That even if the lids are inflamed and you see MGD, there could be a lot more that you're missing there, because a lot of the blepharitis and lid inflammation, a lot of this stuff is secondary to what could be a more insidious problem or a more serious condition underlying that.
That's very well said. Sometimes I think about corneal pathology, and sometimes dry eye, chronic dry eye can lead to different corneal pathologies. And so I'm thinking of stem cell deficiency, right? And there's so many different causes. And one of those could be chronic dry eye. And I feel like, specifically with limbal stem cell deficiency, like that is I feel like it's very, maybe not, it's missed like frequently, right?
Yes.
And then it feels sometimes like a chicken or the egg scenario of like, do I work on the dry first, or how do I manage this? And so, and of course it's going to depend case by case, but guide us through, well, just for that particular
Sure.
pathology in general, like what's your approach? How do you tackle it?
So, limbal stem cell deficiency is, it's funny because whenever I approach the subject or people, I talk about it, they're like, "Oh, it's so rare. You're seeing it, but I'm not." But it's like, well, you probably are seeing it. You just don't know you're seeing it. There's different. You can kind of put it in different categories. In a nutshell, it's just anything that damages the limbus to the point where it's clinically evident and you can diagnose it, right? So that's pretty much it. So we're born with a certain number of stem cells. The stem cell niche works that way. And then as we get older, naturally, especially if there's damaging, what's the word I'm looking for? Damaging factors. So like contact lens, we all think of it as, oh, well, contact lenses, yeah, daily disposable, you'll do great, it's so healthy. But contact lenses are inherently pro-inflammatory. And I think a lot of people miss that. And a lot of people don't focus on that. And contact lenses, well, I mean, hey, listen, I'm a big fan of contact lenses, obviously, but done properly and recognizing the risk with that. So when doctors say that they really don't see limbal stem cell deficiency or they think it doesn't pertain to them, I would object and say it actually does very much. And so when it comes to figuring out how to manage it, probably the most common cause of it in an optometric practice is going to be contact lens induced, chronic dry eye, or something related to iatrogenic factors like medications, et cetera. But it really depends on what is causing the limbal stem cell damage and mitigating that first. So you have to first remove the insult. So if it's medications, change the medications. If it's contact lens, get them out of the contact lens. If it's chronic dry eye, treat the dry eye. But, limbal stem cell deficiency also, I always say you got to put out the fire first and then work on clearing the smoke. So it really depends on how severe it is, how it's affecting the corneal epithelium, et cetera. And then you have an entirely different category of far more severe disease, especially patients with congenital conditions like aniridia, where they tend to present in a much more obvious and severe way. And they're less likely to walk into your door, asking for contact lenses, but they're there as well. And that's in a league of its own. And the management of that can vary significantly depending on the cause of it.
So, Bita, it's funny that you say, I think people it's present a lot more than what people actually
Yes.
think. And I'm going to tell you from personal experience, probably, what year are we in? Probably 10 years ago, I was working at an ophthalmology group practice, loving it. And the cornea specialist there said to me, "Hey, Jackie, I'm doing all their contact lenses. I'm the only OD there." Okay. He goes, "Hey, Jackie, how often do you think you see limbal stem cell deficiency?" He's very curious. Okay. He's
Yeah.
asking because he doesn't know. And I go, never. I don't think I ever see it. And he's like, "Oh,
Yeah.
really? Never?" And I go, like, it was like that moment where I was like, "Oh God, this is not the right answer. Like, I definitely have to have been seeing it." And now I'm like, "Wait a minute, what is it? When am I going to see it?" So if that's really true, because you see you work with students as well, maybe can you take a minute to give us a little education on what someone might be looking for? If you're saying people miss it a lot, so what's the
Yes.
they
I
should look?
was thinking that as I'm saying it, and I'm like, ooh, are we all on the same page here? Yes, let's get on the same page. So, limbal stem cell deficiency will look, in the simplest way I can describe it is if you're looking, the best way to see it, first of all, is with fluorescein under blue light. And typically it presents with delayed staining. So if you put and you're just like flushing that ocular surface with fluorescein and you're like, you look great, you're missing it. Wait for it to dissipate a little bit. And then the late staining is where you can detect it. And quite classically, how it will appear is like almost like a wedge defect. No, not glaucoma. God, no, focusing on the front of the eye. Don't scare me. But it almost looks like if it's sectoral limbal stem cell deficiency, which is typically what you would see, especially if it's early on, right? These are the more mild cases. And this may be the more contact lens induced, but you see this kind of wedge triangular pattern, wider at the limbus and then narrowing as it gets to the center of the cornea. And it has this almost like some practitioners may confuse it with like map dot because the epithelium looks irregular, but very classically, it's just like a whirl pattern sort of delayed staining on the cornea. The challenge with it is when you see limbal stem cell deficiency and it's screaming at you and it's really obvious, you're like, okay, well, there's that. But it's the subtle ones that are really maybe are the ones getting missed. And, when you look at literature, limbal stem cell deficiency is still not considered common. And by no means am I saying it's common, but I am saying the early onset of it, especially in the contact lens population, is far more prevalent than is reported because we just are not catching it. And so it may be mistreated with other things. Like I've seen, actually, it was like last year I had a patient who came in. She was wearing a soft lens for many, many years. Loved her lenses, hates being in glasses. We all have those patients. It's human nature. It's fine. Do you, girl? So she didn't want to wear her glasses. But over time, she said one morning it was as if she woke up and she just couldn't see out of the left eye anymore. And so she was referred. They said there's something going on with the cornea. We think you have recurrent corneal erosions. We think this is related to MAP dot. She had corneal scraping, and it would just come back and it wasn't getting any better. And so eventually this patient landed in my chair And as classically as I described, she actually had limbal stem cell deficiency. So she had this sectoral irregular epithelium, which was being mismanaged or misinterpreted rather. And it's not hard to do, as a like a map dot dystrophy. But the way we managed this patient was she still wanted to be in the lens, so we fit her in a scleral lens. And I saw her literally 6 months later. I actually just presented this case at a conference in Minnesota a couple weeks ago. And within 6 months, the cornea remodeled, and it was as if nothing ever happened. And she was back to 2020 with glasses, where she was 2200 entering. And so I say this also to point out that limbal stem cell deficiency is reversible, especially if it's caught earlier on. You remove the insult and treat it appropriately. So, but anyway, I went a little bit deeper dive than what you asked. But if you let my mind wander, this mouth will just move, my girls. I'm telling you.
No, but that's perfect, because that's a great patient. And I've seen many like that who are not complaining until the edge of that wedge comes into their central vision. And then they're saying, man, I don't know what's going on. I was fine before. I totally fine. No issues, nothing. And really it was this very slow burn of a limbal stem cell that was like happening. And then that wedge just crossed that threshold. And so that's sometimes when they complain. So that was a great description. Perfect.
Thank you.
Like that you pointed out that's reversible too, because when I think about the trajectory, like we're fitting like with the surge of myopia management, right? Like I feel like more kids in an earlier age are going into contact lenses. And so I wonder, I mean, obviously, we could probably predict that we will see more dry eye just from that. But I also wonder if in 10 years, 15 years, 20 years, we'll see kind of an uptick in this limbal cell deficiency. And so I think there's definitely a need for us as practitioners to make sure that we're not overlooking that, but also realizing that it is like there are options, right?
Right.
So do you usually roll with like a scleral lens kind of setup? Do you have other kind of treatment plans?
Oh, well, so obviously the patients we get referred to us are patients who've tried various modalities and they haven't been successful. So it's quite a cherry pick situation where scleral lenses work for them. That being said, the general management of it, there's like a foundational therapy that you do for these patients. And number one, what I already said, remove the insult. So if it's a soft lens, remove the soft lens. If it's the medications, remove the medications, so on and so forth. Whatever you can do to remove that insulting variable, you do that first. Second thing is you want to mitigate any inflammation there. And so patients with limbal stem cell deficiency earlier on may do well with like a soft steroid. You don't need to get crazy and do like pred QID. You could do like a very soft Lotamax once or twice a day, fluorometholone. Watch them every month or so, see how they're doing. Making sure they're lubricating really well, because the limbal stem cells are foundational in allowing a healthy corneal epithelium and remodeling of that layer. So making sure they're lubricating sufficiently. Need be, you could do more long-term therapy like cyclosporin-based medications or other topical immunomodulators. You can kick it up a notch if these patients are having more than just a small clock hour or two, et cetera. If it's more advanced, you can consider serum tears, long-term steroids. That's when you would consider maybe scleral lenses, I think is more appropriate for like the moderate state. That patient, that case I referred to, I was explaining, was more because she really wanted to be back in a lens as well, and she couldn't see. So she had a terribly irregular corneal epithelium and she just could not see. But outside of that, if she would have waited, I would have managed her more conservatively for sure. And then there's the severe where you do more amniotic membrane. The challenge with this is, I do say that it's reversible when it's secondary limbal stem cell deficiency, meaning it's caused from like a secondary insult of some sort. That generally, in my clinical experience, it has been better responsive. But in patients with chronic disease, like I mentioned, aniridia, or really severe conjunctival disease like Stevens-Johnson syndrome, they just have poor protoplasm of an ocular surface and they're at a deficit to begin with. So those are the patients who are going to be much more difficult to manage. And those are patients I think you should definitely co-manage with the corneal specialist, because things can get they can go downhill pretty quickly. So yes, but in general, you start with the foundational therapy and kind of work your way up from there.
Can you talk a little bit about the PROS lens? So you work at Boston Site, which has this, the PROS lens, which is a very well-known scleral lens. And can you talk a little bit like what that is in case someone listening doesn't know what that is, and then how you actually use that in your dry eye care, and what patient you're selecting for that?
Well, thank you for asking that question, because I think when people think about pros, it's one or the other. They're completely confused by what it is, or they kind of bucket it as, well, it's just a scleral lens, right? So I'm happy to fill in the gap here. So essentially, pros is just, it means prosthetic replacement of the ocular surface ecosystem. And the way that we practice, and pros was founded at Boston Foundation for Sight decades ago, far before I was there. And there have been some amazing practitioners. Perry Rosenthal was such a pinnacle of innovation in contact lens. He was actually an ophthalmologist and a corneal specialist, and managed a lot of these complicated patients before commercial scleral lenses were widely accepted. So there was certainly a very significant unmet need at that time. And without the regular availability of commercial scleral lenses, that's when the PROS product was born. The way it functions is just like a scleral lens. It is a scleral lens. It's the nomenclature and what we use to describe it is more unique than a scleral lens, specifically in the way that we design it, the software that we use, the customizations which are available, and most importantly, the training of the practitioner fitting that patient and caring for them. Because when you become someone who's certified in fitting pros and can actually do what we call pros treatment, every single person goes through training. Every single person goes through training to understand these conditions and how to manage them with cornea in particular, because we can't do it alone. And I'd be foolish to say I'm doing this alone. There's no way. And in addition to that, just making sure that they understand the customizations, et cetera. So it's like scleral lens on steroids. But that doesn't mean it can't be available for patients with more mild conditions too. So I get, back when I first started, like 8 years ago, which, holy cow, it's hard to think about now. I would maybe have a patient with keratoconus who would come in, and they were 2400, had never really tried any lenses that worked for them. I put the lens on, they love me. They're like, oh my God, you're amazing. Now I don't see as many of those. Now I may see patients who have been wearing scleral lenses where it hasn't been working for them, unfortunately, or there's some limitations in their vision, or patients with dry eye care who require more advanced treatments. And that's where we kind of fill in that gap. So I hope that helps clarify what it is, but it's really the setup and the way that we practice and the technology that we have access to that makes it what it is. And I think you asked a second part to that. What was the second part of that question about dry
Just
eye?
like how you might use that with a dry eye patient. And are you doing something different, for your, scleral/PROS lens for a dry eye patient versus a cone? Like, are you filling the bowl with something different? Like, how are you treating this patient different?
So absolutely, it's not filling the bowl differently. Actually, clinically, what we've seen, and there's literature that's coming out, and there's some literature that's out there, but just talking about what we fill the lens, we go with the tried and true of preservative-free saline. There we're very the way that we practice in general is very science-based, and we're very mindful because we're dealing with delicate corneas as well. So while we are like to be innovative, and certainly we aim to be, and it's important to be, we go with what's tried and true. So filling it with like a steroid or serum or what have you, I know that you can do it, but just because we can do it doesn't mean we are comfortable doing it. And so any decision that we make, we candidly have that conversation with the patient, and we let them know, hey, this is off label. Would you want to? And, we co-manage patients all the time. And some of these practitioners are comfortable doing that with their patients. And hey, so long as you can monitor them, manage them, and educate them, and you can go to sleep well at night, knowing that you did the right thing by the patient, then more power to you. But for clinically, the way that we practice is tried and true, just preservative-free saline. And periodically, we may do antibiotic prophylaxis in there if we're treating like an active defect or very vulnerable cornea, et cetera. But most importantly, I wanted to address that point that you just raised. And the reason I wanted to make that a point and I didn't want to miss it is because I think it's so tempting to, want to fill that lens. And again, you can, but you always have to maintain for the patient's best interest and be transparent with them. So I just didn't want that point to get lost. But secondly, most importantly, what do I do differently in patients with dry eye or ocular surface disease versus keratoconus? Actually, I would say my fitting style, because when I'm looking at a patient, depending on what their ocular surface disease is, that is going to vastly impact the diameter selection I have for that patient. So if I have a patient with a severe exposure keratopathy and I just had this patient last week, actually. She comes from the South. I hadn't seen her for many years, but she wore a scleral lens that was only this is years ago when I first started seeing her. It was like 16 millimeters. And she was very self-conscious of how red her eye would get. And then I fit her in an 18 and her eye was still getting red. I finished with a 23 millimeter lens on her eye, and the eye does not get red. She's worn the same type of design for 8 years and she is happy. So would I fit a 23 millimeter lens on a moderate to severe cone just for the heck of it? No, I wouldn't. I mean, I would love to. It'd be fun, but I don't think my patients would like me. But it's understanding how the ocular surface responds and not neglecting the conjunctiva, which is so vulnerable in these patients as well. So yes, diameter selection, I think, is probably the number one variable that's different between the two categories.
I love that, Pearl. Since you're such a wealth of knowledge, I'm thinking about some of my other, sometimes tougher to manage dry cases, and I'm thinking of graft versus host, right? And I know that sometimes a lot of our colleagues that can just be really challenging, right? Disease to
Yes.
manage. So any best practices, clinical pearls
Oh
for
gosh.
graft versus host?
Graft versus host disease is in a league of its own. These patients, I would say, I know we're not supposed to have favorites, but I think they're my favorite patients. And it's funny, I was just talking to a colleague of mine. And for those listening who are not familiar with graft versus host disease, this may not be a condition that walks into your door every day, especially if it's primary optometry. But when you run a dry eye practice and you specialize, they find you. And these are patients who've had bone marrow transplants, peripheral stem cell transplants, et cetera, who are reeling from cancer. They do it for cancer treatment or blood dyscrasias. That's the reason for their transplant, et cetera. But they can have an immune-mediated reaction of the body where the graft literally attacks the host. And so there's a very significant and severe inflammatory response throughout the body, eyes included. But anyway, I digress. So with these GVHD patients, it's a condition you treat from the inside out. These are not patients I manage independently solely. And again, I'd be lying to you if I said these are patients I would comfortably be able to manage completely solo, because these patients their care is multifactorial. And they have their oncology team. And very commonly, not commonly, excuse me, let me rephrase this. When the eyes are unwell, you have to ask, is the body unwell? Because when there's an acute inflammatory state, when the patient is having an acute flare, if the GVHD is very active, then you can manage the topicals, the ophthalmic manifestations, and as you should, they generally require steroids to calm down the inflammation, heavy lubrication, punctal occlusion. It can get so bad where they may need a torsorrhaphy. These patients are at high risk of corneal melts and perforations. It can go downhill pretty quickly. But generally, you want to make sure that their GVHD is controlled systemically. Beyond that, it's akin to managing really severe ocular surface disorder, but because again, it's immune mediated, steroids are a really important component there. Punctal occlusion, serum tears, and scleral lenses. And I'll tell you, our group, not me, myself excluded, but we had my colleagues at Boston site came out with a survey. This was a publication a few years ago, and we connected with I believe it's please excuse me if I misname this, but it's the Bone Marrow Network, Bone Marrow Transplant Network, et cetera. and they put out a mass survey of patients with GVHD, and they basically asked them, how, or if you're wearing scleral lenses, how are you doing with them? They had a 92% retention rate. After 18 months, they were still wearing them. And more than half of them said, why didn't someone tell me about this sooner? Which is so profound. And that's the reason I love seeing these patients, because they've been through so much and they're just so appreciative that they can feel better and see better. Now, this is just one category of severe OSD, but take that mindset and how much it affects these patients' lives and apply it to your Sjogren's patients.
Well, Bita, this wouldn't be a to the point episode if we didn't at least ask you what your life lens is.
So I'm gonna go with one that's very simple, literal, and one that's more, I don't want to say philosophical. Well, sure, let's go with that. But the simple thing that I love is my tea kettle that warms up water really fast. Like if I want tea, if I need to cook, I just like press this magic little button and in like 2 minutes I have hot water. So I love that. Invest in one if you have not, especially if you like to cook.
What's
It's
the
just
name
like
of
a
it?
tea. I don't know. I have this one brand. Hold on. You're going to make me get up and look?
Oh, no, don't get up. No. I also
no,
got
but
one
Crate
of
and
these.
Barrel had it. They have so many. Yeah.
I also got one of these, and I totally appreciate it as well for like a coffee.
Right? Anything. Making pasta, you want to put hot water, anything. Like that's for cooking. And then the Phyllis.
Like all the time, right? Like that's your efficiency hack.
Yes, it is an efficiency hack. And then a philosophical personal growth kind of aha moment. As simple as it seems, I've learned that whenever there is an issue that I'm concerned about, or any sort of potential different way of looking at something when you're communicating with someone, always bearing in mind when you are approaching a subject to aim to offer a solution as you present the problem, presenting it together, as opposed to just reporting a problem. Because that's how you make it a we situation and not an I situation.
Oh, Bita. I love that one. Jessilin, I know you're shaking your head on this. As a business owner, if someone brings me a problem without a solution, I'm like, okay.
What do you want from me? What do you
What do
need?
you want? Yes. Oh man, that's a good one.
That's always my first question back to them.
Yes.
They do their grievance and then, well, how do you anticipate solving this? Or
Yeah,
what have you brainstormed? Or what are your thoughts?
Yes.
But it's with everything. It's with patient care. It's with relationships. It's with business. It's with, someone getting your coffee wrong in the morning, whatever. It's with everything, being a part of the solution and not just creating a problem. We don't
That
want
is
that.
great.
We're pointing out one. Yeah.
That's really great life advice. Yes.
Thank you.
Yeah, thank you. Thank
You're
you so much
welcome.
for staying on this podcast with us and teaching us all about just dropping all your incredible knowledge on us.
Thank you.
So
And
much.
thanks for letting me get silly with you guys. I always love chatting with you. It was fun and learning all together. It was a good time. I love talking about this stuff. So thank you so much for having me. It's
Thank
been
you,
great.
Bita.
Absolutely. If our listeners wanted to connect with you or reach you outside of this podcast, how do they find you?
So I think the easiest thing is to just find me on Instagram, Corneal Love. It's one word. Corneal Love's good. And if you want to find me on LinkedIn, go for it. Hit me up. I don't look at that as much, but yeah, go for it. Bita Asghari.
Love it. Thank you so much, Bita. You're amazing. Thank you.
Thank you. Likewise. Thanks for having me, ladies.